Tell me a little bit about how you got into gynecologic surgery.
So, back as a resident, I chose OBGYN really because I wanted to be a surgeon. And I know it's a little hard for this generation to imagine, but I didn't know any surgeons that were women that weren't in OBGYN. Um, it was very uncommon, showing my age a little bit, I guess, but that. That there were general surgeons, there wasn't colorectal surgery. I didn't know any urologists. I think maybe one pediatric surgeon that was a female where I went to medical school. So it was really choosing OBGYN for a lot of reasons, but certainly for me, a major motivator was I did like to do surgery. So, and at the time, I came to University of Michigan to train, and because it did have a reputation, especially Dr. George Morley, past SGS president, who was a GYN oncologist and pelvic surgeon, was known to train female surgeons and had done a lot in the field to help promote women as surgeons. So I was fortunate enough to come to Michigan and work with him, work with a very young John Delancey at the time. And urogynecology didn't really exist at that point. We were more just pelvic surgeons, if you will. And, but it was, the start of a great career, and I have enjoyed every minute of it.
Perfect. Thank you. Tell me a little bit about who have been in addition, to Dr. Delancey, who have been your sponsors and your mentors over the years?
Yeah, I will say that, again, such a different time. Certainly, Dr. Morley, he brought me to my first SGS meeting. I think that was in 1991. Some of the people in the audience might not even have been born then. And there were 3 women at SGS at that time. Hard to imagine. SGS itself probably had about 50 members then. It was still small, but only about 3 women, if pretty sure if I remember that correctly. So I think that I was, went to Mayo Clinic to do what was then a 1-year surgical fellowship because there weren't urogynecology fellowships yet at the time, and worked with Javier Magrina and Jeff Cornell, and was kind of taken into the Mayo family. And so certainly Ray Lee at the time, Bobby Scholl, and then I was fortunate to join Linda Brubaker in Chicago, and we were long-term partners and helped really develop the field of urogynecology. So, we had mentors and sponsors, but I also say that we had good colleagues who were very supportive as we developed the field, and things were really changing. And there were so many great people that we got to work with. Mike Aronson, again, John Delancey, lifelong mentor, friend, partner here at Michigan. Those are just off the top of my head some of the people I would say.
There's a lot of the same names keep coming up. So, and you're in good company. Some of those individuals have also been interviewed as part of this SGS compilation. What in your mind makes a good gynecologic surgeon?
Yeah, I think there's somewhat just, you have to have good basic surgical skills. Let's start with that. I think, doing the surgery itself is and sometimes the easiest part. So it's knowing when to operate and when not to operate. It's knowing what symptoms you can fix and how you can help the patient and whether that includes a surgery or not. So I will start with that. I think intraoperatively, you have to, understand the anatomy. You have to understand how to get out of complications. I think that's the thing that, takes some time, some experience. I mean, I see residents and fellows who, I think, you can say they have good hands. I would also say they have good eyes So that, it's being able to see in three-dimensional, and also to be able to see tissue planes and be able to see the anatomy and be able to think about how you manage when things aren't going absolutely perfectly. And I think that's, somewhat the mark of a good surgeon. Finally, I would say you have to be able to be calm, and you have to be able to reassure the team members. Surgery is a team sport. And there's no place in the OR for ego, and there's no place in the OR for temper. And not all of us are going to be perfect every day, but that really does need to be. You need to leave all that outside when you come in and just focus and have all your attention on the patient. So I think that ability to focus is really important for a good surgeon.
The theme of the upcoming meeting in March is surgeons as change agents. What does that mean to you? What changes have you seen over the years, and what do you think might be, waiting for us in the future?
Yeah, so I think for me that surgeons as change agents. I think one thing is that most surgeons are able to take, I think, a complex patient history or diagnosis or anatomy or situation, and be able to think through that logically and create a plan and hopefully to execute. And I think that, as change agents, those skills that you have to be a good surgeon actually make you a very good leader in an institution, whether that's a division director, that's a chair, that's a dean, that's a practice manager, et cetera. So I think the ability, again, to listen, to take a lot of information in, to be able to formulate a plan and to execute, um, that that's what it takes to actually make change. And so I do think that surgeons make great leaders. And I think that execute part is really important. I also hopefully you're able to manage complications, so understand what are the positive and negative consequences of doing a surgery. And I think all of that is really important when you talk about change management.
So, along the lines of the SGS meeting, you mentioned when your first SGS meeting. Can you tell me a little bit about, in general, what SGS has meant to you in your career?
Yeah, SGS has been really important in my career. It opened the doors for me to, meet other pelvic surgeons and other urogynecologists across the nation. It's so in terms of mentorship, there's been times, I can recall, making a phone call to someone to say, I have this patient who has this problem I haven't seen before. How would you manage that? So it opened those doors to give me those opportunities. Obviously the meetings, you've learned a tremendous amount. Certainly the science and the quality of the presentations have changed so much. When I first went to SGS, there were generally case series, some debates. It was a very open, a little more contentious, I will say. It was frightening to hear some of the challenges of the predominantly, as I say, male audience at that time, to get up and how they would critique the papers were discussed, and it was a little bit more, I would say, hardcore, but you also learned a lot, and you learned how to defend yourself and how to express yourself in that type of a situation, which have all been good lessons. I think SGS, I made tons of wonderful friends. I mean, I think about Holly Richter. I think about Becky Rogers. I think about so many folks that, are SGS members that over the years were really important and become good friends and colleagues. It's a place where you can take your fellows or residents, and they can, get excited and learn about what it means to be a gynecologic surgeon. So I think as far as leadership training and the research and everything that SGS offers, I mean, it's really been pivotal pivotal. Excuse me, I can't talk. It's been pivotal in my career.
And what keeps you coming back to the meetings now?
Yeah, I think that there's still new things. I think if you quit learning, and you're not open to continue to learn and to grow as a physician, as a surgeon, as a person, as a leader, then it's time to retire. So I think that I come to SGS to learn. I come to SGS for the camaraderie, to see friends, to see my former fellows. It's a great opportunity to, to socialize with folks, to see if there's something brand new, the latest gadget, if you will, or to. So I think those are all the reasons that I come back to SGS.
I'm muted. Sorry. Last question. Favorite surgical instrument and why?
I know that was a. I think my favorite surgical instrument is a sucker. Um, I think I can do a hysterectomy. I know I can do a vag hyst with the sucker. I've, the way I use it as a pointer, I use it as a retractor. I do so much more than just use it as a instrument to aspirate with. I think for me, the sucker has cut here, don't cut there, stop, clamp, tie. Um, you know, don't do that. Listen, focus right there, and help, takes a little tissue down or things. So for me, I'm going to say the sucker is my favorite instrument.
And I guess my follow-up question to you then is, do you let anybody else hold it during the surgery?
If I'm operating, I have to have somebody. If I'm the primary surgeon, I'd let somebody else. But otherwise, very rarely.
Yeah.
Though I think it's part of. I try to teach the fellow or the chief resident to be able to use the sucker as I do, because I think it is very important if you're going to first assist.
I only asked because the sucker is also Deb Meyer's favorite instrument,
I
and
believe that.
she doesn't let anybody else hold it.
Yeah. Well, yeah, Deb's a good friend. I have to add her to that list of my SGS colleagues that have
Yeah.
been so wonderful over the years. Yeah.
Yeah.